Our transfusion reaction series, The Unseen Threats. In part 1, if you have not seen, you can see there we have discussed about the acute hemolytic reactions. In part 2, we have covered the FNHTR, anaphylaxis, Trali and TACO, and this is the last part. It is about the threats that you don't see coming. These are the reactions that develop hours, days, or even weeks after the transfusion is long over. By the time the patient is symptomatic and the cause is no longer at the bedside. So it is the hidden in the immunological memory. This is your overview slide. This is your navigation map for today's journey for the whole session. We will be discussing about the DHTR, that is delayed hemolytic transfusion reaction. The word delay is a key. The patient was fine when they left the transfusion suite. Days later, they become jaundiced, anemia, feverish, and no one connected to the blood they received the last week. The mechanism is immunological memory. An alloantibody that was undetectable at the time of transfusion re-emerges in response to the re-exposure of the forgotten antigen. It is stealthy because pre-transfusion testing appears completely clear. Second is HHS, that is hyperhemolysis syndrome, the bystander catastrophe. Label it deliberately. Not only does it cause the immune system destroy the transfused donor red cell as in DHTR, it also destroys the patient's own native cell in the bystander fashion. This means the patient end up more anemic after the transfusion than before it started. It is seen most exclusively in the sickle cell disease patient. It is paradoxical, devastating, and potentially fatal. Third is a septic reaction, the immediate bacterial threat. Unlike the other, this is non-immune mediated reaction. It is direct contamination of the blood product. It manifests during or within the hours of transfusion with dramatic fever spikes, rigor, and shock, most commonly associated with platelet transfusion due to room temperature storage. And the last one is the TA-GVHD, transfusion-associated graft-versus-host disease, the most feared and the least treatable. Viable donor T lymphocytes engraft in an immune compromised recipient and mount an immune attack against the host tissue. The mortality exceeds 90%. The treatment is purely preventive, irradiation of the blood product, remove viable lymphocytes before the transfusion. So let's get started. Timeline is important, most clinical important in this series. So the timeline runs from day 0, that is the transfusion day, to the day 28. The danger zone is highlighted between day 3 and day 14. This is the window in which the vast majority of the DHTR manifest. However, reaction can occur late as 28 days, and this is critical for the patient follow-up. The onset period is day 3 to day 14 but can goes up to day 28. Why is there a delay? Unlike an acute hemolytic reaction where a preformed antibody destroys the red cell immediately, in DHTR it requires the immune system to mount a secondary response. Memory B cell triggered by the re-exposure to the foreign antigen on the donor red cell, which proliferate and produce a surge of IgG antibodies. This process itself will take 3 to 7 days to generate a sufficient antibody concentration to cause clinically apparent hemolysis. So the driver in this DHTR is the anamnestic IgG response. So the alloantibody response was made in the past, typically from prior pregnancy or transfusion. Over months to years, the antibody titer fell below the detection threshold of a standard pre-transfusion antibody screening. The blood bank issued the compatible blood units because the screen was genuinely negative at the time. The foreign antigen is transfused and the memory B cell recognizes it. Rapidly high affinity IgG is produced and which will lead to the extravascular hemolysis. So the misdiagnosis problem in the DHTR is in the immunocompetent patient. So in these patients, DHTR is often subclinically just as unexplained drop in the hemoglobin with the mild jaundice and get attributed to the another cause. Then the danger zone is a sickle cell disease where DHTR triggers the hyperhemolysis syndrome with potentially catastrophic consequences. This is why all transfusing clinicians must maintain a high index of suspicion of DHTR in any patient who has transfused within 3 to 28 days and present with the unexplained anemia, fever, and jaundice. Full attention. So the step one is the primary sensitization. Prior exposure to the foreign RBC antigen through pregnancy, that is fetal cell entering the maternal circulation, or prior transfusion or transplant, the immune system mount an primary response that will generate the IgG alloantibody against the minor antigen, for example, KIT, RHC, or E. Cal Duffy. So these memory B cells and the memory T cells will form. Then step 2, it's the antibody decline. Over the months to year, antibody titers decline. They fall below the sensitivity threshold of routine antibody screening, that is your ICT. When the patient arrives for the next transfusion, the antibody screen will appear completely negative. This is not the lab error. The titer is generally undetectable and the blood will be compatible and is issued. Step 3 is a re-exposure. Now this transfuse compatible unit contains the forgotten antigen. The donor red cells are now circulating in the recipient bloodstream. The fourth step is the amnestic response. That memory B cell primed from the original sensitization will rapidly recognize the antigen, and secondary immune response, that is IgG antibody production, will be there, and it is rapid, massive, and have a high affinity that will occur within 3 to 7 days. For example, KID antibodies are classically associated with the DHTR due to their tendency to decline in the titer quickly and their potent dosage effect. Step 5 is the extravascular hemolysis. In this, IgG-coated donor cells are recognized by the Fc receptor on the splenic macrophages, which can cause the phagocytosis and the destruction of the antibody-coated cell. This is the extravascular hemolysis because it is occurring in the spleen and liver reticuloendothelial system. Unlike the intravascular hemolysis which we saw in the AHTR, there is no hemoglobinemia or hemoglobinuria, unconjugated bilirubin rises or LDH rises or haptoglobin fall. So that all you will see in the AHTR, not in the DHTR. So in this, the clinical presentation, there is a constellation of the finding. There will be unexplained drop in the hemoglobin or failure to achieve the unexpected post-transfusion rise. Fever, jaundice, there will be rising unconjugated bilirubin, new positive DAT, and newly detected alloantibody in the post-reaction sample. So this circle closes. The patient is now sensitized to a further antigen, making the future transfusion increasingly complex. Of the extravascular hemolysis. So in this, the macrophages engulfing the antibody-coated RBC. This is a hallmark for the DHTR. IgG antibody coated the donor red cell surface after the amnestic response. The splenic macrophages express the Fc gamma receptors which recognize and bind the Fc portion of the IgG. This will trigger the phagocytosis and the RBC is engulfed and destroyed within the macrophage. Contrast with the AHTR, in acute hemolytic reaction, there will be activation of the complement which will activate the MAC and causes the direct intravascular lysis, which will lead to hemoglobinemia, hemoglobinuria. Whereas in DHTR, none of these will be seen. The hemolysis is quieter, extravascular, and the urine is clearer. The four cardinal signs of DHTR, there will be unexplained drop in the hemoglobin, the most common and consistent finding. So patient hemoglobin fail to rise as expected post-transfusion or actively falls. If a patient receives 2 units of RBC and their hemoglobin goes by 2 gram by deciliter instead of expected 8 to 10 gram by deciliter, or hemoglobin actually drops, then think of the DHTR. This is called inadequate increment. Second is fever and jaundice. In this, fever from the immune activation, jaundice from hemoglobin breakdown, both together days after transfusion, which is a classic DHTR picture. There will be new positive DAT. That was a negative before the transfusion, but now it is positive after the transfusion, showing IgG coating red cells. This is strong evidence of the alloantibody mediated destruction. The polyspecific AHG card will be positive and the monospecific IgG card confirms the type. Fourth will be the newly detected alloantibody. Post-reaction sample reveals a specific alloantibody that was not detected on the pre-transfusion sample. This is the management of DHTR, which is primarily supportive as there is no antidote. So on the left side you can see the supportive management. So first, maintain the hydration. IV fluid to maintain the renal perfusion are essential. Free hemoglobin and heme breakdown products can precipitate in the renal tubule, which can cause the acute tubular necrosis and renal failure. So there will be brisk urine flow, that is protective, and monitoring of urea and creatinine daily is significant in DHTR. In severe cases with rising creatinine, nephrology input may be needed. Second is the medicate for the symptoms. Whatever the symptoms are there, we have to give the symptomatic treatment. For example, for fever, you will give paracetamol and monitor the other parameters like bilirubin, whether it is severely elevated. Consider the role of exchange transfusion in the life-threatening condition. For the future transfusion, this is the most critical long-term management point. In further transfusion, there must be antigen negative cross-match compatible red cell and transfuse with the identify alloantibody specificity in mind. On the right side, there is a lab investigation. Two important lab findings confirm the DHTR. That is a new positive DAT, which will show IgG plus minus C3d on the post-reaction sample as compared to the pre-transfusion baseline, and a newly detected alloantibody in the post-reaction serum or plasma by the ICT or antibody panel. So we have to order that plus antibody screen and antibody identification. Plus you will see the LDH level, bilirubin, heptoglobin level in the patient, in which there is an unexplained hemoglobin dropped or jaundice within 3 to 28 days of transfusion. Rule in the DHTR is a permanent preservation of the antibody record. This is mandated by the AABB and CAP, College of American Pathologists standard, as well as BCSH guideline in UK. The rule is absolute. Once a clinical significant alloantibody has been identified in a patient, it must be permanently recorded in that patient blood bank history, and for all the future transfusion must use antigen negative blood even if the antibody titer later falls below the detectable levels. Why? Because the antibody will come back. The memory B cell persists indefinitely. If you ignore an old positive antibody result and issue the antigen positive blood because the current screen is negative, you can cause the DHTR or it can even worse. So there should be high risk shielding for the sickle cell disease patient and the thalassemia who are at the highest risk of DHTR because they will require the multiple transfusion over the lifetime, giving many opportunity for the sensitization. For these patients, prophylactically extended antigen matching is recommended at minimum matching of RH system. So this approach significantly reduces the rate of alloimmunization from 30 to 50% to below 10% in the sickle cell disease patient. Next is the hyperhemolysis syndrome. Is one of the most clinical, dramatical, and potentially deadly complication in the transfusion medicine, and it is most exclusively seen in the patient with the sickle cell disease. The threat that makes the HSS unique, it is severe paradoxical form of DHTR. Why paradoxical? Because it is exact right word, as the treatment of HSS is opposite of what instincts tell you to do profoundly anemic patients. In DHTR, hemolysis target the donor cell, whereas in HSS, the hemolysis extend to the patient's own native set cell, hence bystander. So you transfuse blood to the help patient, but they end up with the less hemoglobin than before you started. So the paradox is a bystander destruction. Two populations of red cell are destroyed simultaneously. First is the donor RBC and second is the patient own native RBC. So donor RBC it is targeted by the alloantibodies as we saw in the DHTR or sometimes even with the autoantibody. Whereas patient own native hemoglobin sickle cell red cells are destroyed by the innocent bystander by the hyperactive macrophage and complement system. So the net result is the post-transfusion hemoglobin is significantly lower than the pre-transfusion baseline. So this is the diagnostic hallmark and is also what makes it so dangerous. More transfusion will make it more worse. The result, profound anemia. Hemoglobin can fall to life-threatening level 3 to 4 gram by deciliter rapidly. And the patient may present with the symptom of severe anemia, chest pain, dyspnea, cerebrovascular events. So in sickle cell disease patients, this is particularly dangerous as sickling is exacerbated by severely anemia and hypoxia. The clinical hallmark is the reticulocytopenia. In a normal hemolytic process, the bone marrow responds by producing the more reticulocytes, whereas in HSS, the bone marrow response is suppressed, probably due to the cytokine-mediated inhibition or direct macrophage-mediated destruction of erythroid precursor. The reticulocyte count is paradoxically low despite severe hemolytic anemia. This reticulocytopenia is a clinical fingerprint of HSS. So always check the reticulocyte count when we are suspecting the HHS. So in this slide, we will understand why HHS spiral out of control and the counterintuitive but critical management protocol. So first you can see in the mechanism the macrophage activation. So hyperactive macrophage in the spleen and liver are the primary drivers. In the sickle cell disease patient, multiple prior transfusion have primed the macrophage system. The new transfusion triggers a state of hyperactivation. Macrophages become indiscriminate in their phagocytosis, destroying not just the antibody-coated donor cell but also the native RBCs. Then it will activate the complement. So runaway complement activation amplifies the destruction. The C3b coating of a red cell, both donor and the native cells, mark them for the additional phagocytosis. Now the complement mediated membrane attack complex may contribute to the direct intravascular lysis. The complement cascade itself is a self-amplifying. Once triggered, it will accelerate. The third is the bystander hemolysis. The combination of hyperactive macrophage and the complement generate a non-specific hemolytic environment. Any red cell in the vicinity is at risk. The patient own HBSS cells, already fragile and are prone to sickling, are particularly vulnerable. Now, how we can manage? By stopping the transfusion. That means to avoid further transfusion, which is the important rule in these patients. This is a counterintuitive core principle for the HHS management. Every clinical instinct says that the patient is profoundly anemia. Now give more blood. But in these conditions like HSS, further transfusion provide more substrate for the hyperactive immune complement system to destroy. So that will as work as fuel in the fire. So each new unit which you are transfusing may worsen the hemolysis exponentially. Transfusion must be withheld unless until the hemoglobin is at the immediate life-threatening level and there is no option exists. For the first-line therapy, we can use the immunosuppression, IVIG or systemic steroids can be used. For the refractory cases, the biological therapies like rituximab, erythropoietin injections can be used. This is the septic transfusion reaction. It is the one category in this series that is not immune mediated. It is purely microbial direct contamination of the blood product with the viable bacteria. Why does the blood become contaminated? Blood is collected from the donors via venipuncture. Despite the rigorous skin disinfection, low-level bacteremia in the donor or skin surface contamination can introduce the organism into the collection bag. More commonly, it is a gram-positive skin commensal, streptococcus or staphylococcus, enter at the time of the collection. Once they are inside the bag, the bacteria have a nutrient-rich environment to multiply during the storage. So the organism gram-negative bacteria are the most lethal, Yersinia enterocolitica, because they can specifically adapt to grow at the 4 degrees Celsius at the temperature where we are storing the red cells. The gram-positive organisms, Staphylo and Streptococcus, they are less endotoxic but can cause a significant sepsis. Why platelet more often cause the sepsis? Because they are stored at the room temperature for 5 to 7 days, and this is necessary to preserve the platelet function, but at the room temperature this is the ideal bacterial growth temperature, and a contamination rate of approximately 1 in 2000 to 1 in 5000 platelet unit is estimated. So there can be acute onset, the 4-hour rule, that is a blood safety principle. The component of a blood should be administered within the 4 hours of removal from the controlled storage. Bacterial proliferation increases dramatically once the product warms to the room temperature. The clinical feature includes the temperature spike of more than 2 degrees Celsius, often reaching to 40 to 41 degrees within minute of starting the transfusion. Violent triggers, shaking chills much more intense than the FNHDR, severe hypotensive shock, and DIC. How we can manage it? Stop the transfusion immediately, keep the IV access, give the antibiotics, IV antibiotics, send the blood cultures from the 2 different sides of the patient, culture the blood bag and give supportive care, notify the blood bag immediately. Transfusion-associated graft-versus-host disease. It is the most feared complication in the blood transfusion. There is no effective treatment once it is established. It kills more than 9 out of 10 patients it affects. Its prevention is absolute and entirely within our control. The mechanism behind is a cellular engraftment and attack. What is happening is in TA-GVHD, it is caused by the viable donor T lymphocyte contained in a non-irradiated cellular blood product. In a normal human being, immunocompetent recipient, these foreign donor T cells are rapidly recognized and eliminated by the recipient immune system. So there will be no problem. But in the vulnerable, immunocompromised patient, the donor T cells are not eliminated. They engraft, establish themselves in the recipient lymphoid tissue, and then mount an immune attack against the recipient own tissue, that is a graft versus host. So the target organs, there is a clinical triad of TA-GVHD. So in the skin you will see erythema, maculopapular rash, blistering, and then desquamation usually starts on the trunk. In the gut there will be voluminous bloody diarrhea, sometimes approximately 10 to 15 liters a day. Abdominal pain, nausea. In liver you will see the hepatocellular damage, raised transaminases, rising bilirubin levels, and liver failure. In bone marrow, there will be a picture of pancytopenia, which is the most lethal feature. Donor T cell attack the recipient hematopoietic stem cell, which can cause the marrow aplasia, that is a life-threatening infection and bleeding condition. So the pancytopenia is what makes a TA-GVHD different from the transplant GVHD. In the later, the donor marrow provides the hematopoiesis, whereas in TA-GVHD, the donor T cell destroy the host marrow without providing a replacement. So you can see this in 1 to 6 weeks post transfusion. The delay reflects the time needed for the donor T cells to engraft, expand, and mount an immune response. By the time symptoms appear, and the diagnosis is often missed because the transfusion was week ago, which will maintain the high index of suspicion. There will be high mortality, more than 90%. Why? There is no effective treatment. Immunosuppressive agents like steroids, ATG, have been tried without success. They cannot undo the established T cell engraftment attacking the marrow. By the time pancytopenia develops, infection and bleeding become rapidly fatal. So how we can diagnose? By the chimerism studies, the molecular analysis of the blood or tissue showing both donor and the host DNA coexisting. PCR based HLA typing differentiates the donor from the host cell. Who are at the risk? So immunocompromised patient, BMT stem cell transplant recipient, congenital immunodeficient lymphoma, leukemia, or on chemotherapy patient. Neonates, premature neonates, exchange transfusion, recipient intrauterine transfusion, HLA match transfusion if a donor and recipient share a HLA haplotype. The recipient may not recognize the donor cells as foreign, allowing the engraftment even in the immunocompetent recipient. This is why directed donation from a family member require irradiation regardless of recipient immune status. And the patient on the purine analog drugs that can be profound for the T cell suppression. So this is your summary slide of this session. So in this you are seeing the DHTR. Onset is 3 to 14 days. The key, remember, it is delayed, not immediate. The culprit is IgG alloantibody, and the key clinical sign explain drop in the hemoglobin with jaundice and failure to achieve the post-transfusion increment. Primary prevention is permanent antibody record. Never transfuse antigen positive blood once an antibody is identified. Extended phenotype matching for the sickle cell disease patient and the thalassemia patient. Next is HHS. Days overlap with the DHTR timeline, but it is more acute in the progression. The culprit is the hyperactive macrophage with the complement cascade causing the bystander hemolysis. The key clinical sign is the hemoglobin drop below the pre-transfusion baseline, reticulocytopenia, that is bone marrow suppression, and pathognomic in the sickle cell disease. How we can prevent? Avoid the transfusion where possible in the sickle cell disease patient, extended phenotype matching to reduce sensitization, and when HHS occur, IVIG plus steroids and no further transfusion. Next is septic reaction. Onset is less than 4 hours during or immediately after the transfusion. The culprit is a bacterial endotoxin from the contaminated blood product. Clinical signs include the temperature spike more than 2 degrees with rigor, hypotensive shock, DIC, and no hemolysis is seen. How we can prevent? The 4-hour rule, visual inspection of the unit before the transfusion, and the bacterial screening of the platelets. Next is TA-GVHD. The onset is 1 to 6 weeks post-transfusion. The culprit is the viable donor T cell engrafting in the immunocompromised recipient. The key clinical sign is skin rash with the profuse diarrhea, pancytopenia. How we can prevent? By giving the blood irradiation, gamma irradiation or X-ray irradiation of all cellular blood products at the patient who are at risk, and it is 100% preventable. So the quick mnemonic is D, delayed hemoglobin drop, that is DHTR. H stand for hemoglobin goes lower post transfusion in HHS. In septic, S, spike in temperature plus shock. In TVHD, T, that is T cell causing fetal tissue attached. Now the universal first response to any suspected transfusion reaction. So first step is to stop the transfusion, and second is to maintain the IV access. Third is assess the patient on the basis of A, B, C, D, and fourth is to notify the blood bank for the clerical check and other lab parameters. The fifth to eighth step is the investigation and the reporting phase. So the fifth step is to collect the sample, and this should be done within 1 hour of the reaction onset. The diagnostic window closes rapidly as hemolysis marker changes. So you have to send the samples for the investigation. Clerical check is the sixth step. Seventh step is to give the supportive care. Eighth step is to documentation and the reporting of the reaction. That concludes the transfusion reaction, the unseen threats, part 3 of the transfusion series. And we have seen the summary of all the reaction in this. Thank you for watching the Transfusion Vital. If this series has been helpful to you, please like, subscribe, share with your team members, colleagues, and leave your question in the comment box.